Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Fuster Heart Hospital in the cardiac cath. My name is Dr. Pedro Moreno. I'm an interventional cardiologist and I will be your moderator today. We would love to hear from you, so please send us your question directly through the website or on YouTube. And remember, you can review all our previous Structural Heart Life Cases at ccclivecases.org. Please let me transfer you to the cath lab for a very interesting case.
All right, good morning, Pedro, and our viewers of our Structure Live webcast, which is actually getting a lot of momentum now. And the type of cases which we are showing and will be a different one, will be the first live relay of the TTVR case. We are done in the past, in the valve, tricuspid valve restenosis, we put a sapien that we did about 3-4 years ago, but Evoque TTVR will be done first time. So myself, then on my right side, Dr. Kini, then Dr. Tang, and Sail Khera, and we have our fellows here, Maria and Krishna. And then on the echo, we have Lucy Safi, and we also have a structural fellow will be assisting her, and of course rest of our team with our anesthesiologist. And we want to just show this case, which is another new device which has been approved by FDA, and our cardiac anesthesiologist is Dr. Casey Drobin. With all our disclosures shown here. So this case is the transcatheter tricuspid valve replacement, TTVR, for severe lead, which is the cardiac implantable electric lead associated TEER. And we'll show you what it means. So two things wanted to show because of the increasing changes in the nomenclature. We usually, most of the regurgitation or stenosis from mild, moderately severe to severe, but in the tricuspid, they added two new terminology, massive and torrential. As you can see, in terms of the venous coarctation, EROA, regurgitant volume, significantly increasing as we go further. Maybe Gilbert and Sail can comment on it, why we added these two new terminology, massive and torrential, in last 4 or 5 years only.
Yeah, I think that is a very interesting point because, mild, moderate, severe, what was happening was you try to do a procedure on severe patients and they would have benefit in terms of a clinical endpoint, but the lesion would still be severe. So I think severe was actually a bigger spectrum because you could have very severe and you could have little severe. So that was sort of divided into torrential and massive, and then making 2-grade improvement as a good clinical endpoint for outcomes.
Beautiful. Yeah. So key is that knowing that severe could be anywhere from your ERO from 40 to 200.
Yeah.
So at least by this you are able to divide massive versus torrential and so. Okay. Now the second is the classification based on the etiology. We know majority of them are functional, and in the functional is the atrial and ventricular. Then the lead associated, implantable device associated, related or associated, and then primary TR. So primary TR we all know, whether prolapse or rheumatic heart disease happens in about 8-10% of cases. And then lead related is about 5-6%, but majority is the ventricular functional TR or some atrial functional TR, and happens because of the dilatation of the right ventricle in response to the left ventricle. So left-sided disease causing the right-sided dysfunction, and we know that all the trials of the left-sided, whether mitral, aortic, anytime you have a right-sided involvement, right-sided regurgitation has a distinct independent marker of bad prognosis, and therefore the right side is really becoming very, very important in last few years to understand that we cannot leave it alone because it is associated with a bad prognosis, particularly your left-sided valve and so. So with that note, let's go further. This is maybe Sahil can comment on it, because the term we use, lead associated versus lead related tricuspid regurgitation, and these are the cardiac implantable electronic devices, and this is what disease entity which we kind of thought yes, no, but now has become clear cut. and it makes about 6 to 8% of the severe TR. Sahil, you want to say associated whether related means what does it mean?
Initially everything was clubbed together, and then what we realized is that when you have lead related TR, that means either there is lead adherent to the leaflet or there is a perforation of the leaflet. So there's some way the lead is actually causing, if at all, your TR. Then there's a lead associated TR, that there's no causative relationship between your lead and TR. And what happens is you put a lead in these patients, at least 7 to 30% or 1/3 of them could actually have some kind of moderate TR, which actually progresses. And the evolution of TR again is dependent on your usual risk factors, atrial myopathy and atrial fibrillation, or some kind of an RV dysfunction. But they're different terms, they're different etiologies. So removing a lead in a lead associated TR may or may not help your TR. So that's why it's important that if you have lead related TR, yes, you can think about extraction if the lead is not very old, but lead associated, usually the evolution of TR is your usual risk factors and not really the lead itself.
And that's an important point. So this field of knowing this 6-7% of these cases, having a severe tricuspid regurgitation with a lead related TR, the lead extraction is becoming very common procedure to be done in these patients, and with a good success. And of course, they use a laser to remove the leads. Rarely you do a surgical. But what if the patient has ICD, and now you want to remove the lead and you want to put a valve? What would you do with the ICD on that case?
Yeah, no, Gilbert, or Dr. Kinney, you want to take that question?
That means epicardial, or what we do in those situations? Because if you have a lead-created trouble, now you are putting a TR or TriClip, or more importantly, Evoque. How would you bridge that patient? Because we are getting 1 or 2 patients of that kind which are under discussion. That patient is essential. They have the ICD, and you cannot get away from it. That how do you manage those cases? You cannot just remove the lead for them because something else needs to be done.
Yeah. Now, these patients are seen with the EP when we see them in the office. So that's the time they make a determination, how important this lead is for the patient. And if we think it's important, they are with us in the procedure. As the procedure is done, nowadays we have leadless, and then immediately they place the whatever, whether it's a pacemaker, AICD at that time.
Yeah, I think for the audience, very important to distinguish these two etiologies Sahil has mentioned, number one. And number two, if you plan for a TTVR approach, you have to involve our EP colleagues, because if you cannot extract the leads, that lead can be jailed. So that needs to have a contingency plan. And if the lead will be extracted, we have to also be mindful that with lead-related TR, for example, if the leaflet gets damaged, it can compromise our ability to do TTVR or even TTEER, because it's much harder to capture that damaged leaflet. So we have to look at imaging. We have to have a multidisciplinary heart team discussion to discuss what's the safest approach for the patient, because the patient is here for TR treatment.
So let me ask you one question, simple, and I try to go through the literature. I can tell you this, there's so much immense literature about tricuspid. Just like our tower literature, tremendous tricuspid. Mitral is still less, but tricuspid. What harm it is? Lead is behind. It has created a anterior leaflet damage of the tricuspid valve. Why don't you just put a Evoque and let the leaf be impinged on the one side? Will that still be working?
So there are two types of leads, right? You have an integrated bipolar and non-integrated bipolar lead. So the integrated bipolar lead, if you have an interaction from the valve, theoretically, you could have that lead sense that valve motion.
Yes.
So it can charge irrespective of being in primary cardiac, etiology. So we always look at two things. Number one, is the ICD lead for primary prevention or secondary prevention? If it's a primary prevention ICD lead, then it becomes really, really challenging, and we need to think about some kind of a subcutaneous ICD. If it's a secondary prevention ICD for non-ischemic cardiomyopathy, yes, you can think about not doing anything. But if it's for ischemic cardiomyopathy, you still have to have a contingency plan. And if you jail the lead and it's a non-integrated bipolar, we've done so many cases, we've had no issues. Just make sure you do a pre and post-op ICD interrogation for your patients.
So just coming back to the point, Pedro, I wanted to emphasize on these two things. These are the new terminology. And I didn't know until 48 hours ago. I'm learning, so I'm sure a lot of our audience will be learning that one is the lead associated and the other one is lead related. And very important, lead associated, you're taking the lead out is not going to make much difference. It is the lead related, that's where the lead has to come into equation, because lead associated is your natural TR progression, which is causing the disease process. And in our case, it is lead associated, and you will be able to show us exactly, and of course Dr. Lucy Saifi will show that how the lead is interacting with associated.
Lead related?
So with that note,
Associated.
yeah, so
Didn't you say
I don't know,
stuck?
I was told associated, we'll see it. Let's see. We'll
Stuck
see it.
behind,
If we
no?
can figure it out, then everybody will figure it out. So, okay. So let's go to brief presentation of this case. 88-year-old female, patient has exertional dyspnea and non-ischemic cardiomyopathy, had a severe MR, got the TEER, has done well, but continues to be short of breath, EF about 40%, and then has a severe tricuspid regurgitation, lead associated TR, good medical therapy, we paced, we did a right heart cath, non-obstructive CIED with mild pulmonary hypertension. And this is where we are, but I think we should be able to show the active one, but let me take you through ME, the various views with the colored biplane and transgastric biplane view. Okay, so Lucy, you want to show something? Yeah.
For clarification, the differences between the lead associated and lead related is purely echocardiographic, or how do you actually differentiate?
So imaging mostly,
imaging.
because
Leaflet.
you don't have, if you look at, Lucy will show you where this lead is lying. It's not on a leaflet. It's not causing leaflet perforation. It's actually quietly lying in a commissure.
Yeah. So basically, there are three leaflets of the tricuspid valve: anterior, posterior, and septal. So if any of those leaflets are impinged, they have destroyed, they have abrasion, they have restricted motion, then will be lead related. And if lead is just lying inside the tricuspid valve, is a lead associated. Now let's say, Lucy, you tell us now whether
CT
it's associated. Get the live echo feed, please.
All right, good morning. And so here you can see our starting 4-chamber view, mildly reduced LV systolic function and RV systolic function. Focusing on the right heart now, you can really appreciate the size of the right atrial enlargement and overall mildly reduced RV systolic function. Let's focus on the TR today. Remember, this patient was prehabbed, so they did come in for diuresis prior. So the TR was severe. It still is severe when we quantified it. But just going through our pictures here, this is our RV inflow view, and you can appreciate, in using biplane color, the amount of TR that really comes from throughout the anterior and septal coaptation plane mainly, and centrally through the small gap there. So going through our NPRs across the screen, this is your posterior, anterior, septal, and lateral part of your annulus. You can appreciate that ICD lead here in your posterior and septal commissure. And then with color, again, you can see the tricuspid regurgitation, but really it's better to take a look at this from the transgastric view, which I'll show you in just a minute. And so we have to do our baseline measurements, and this is compared to our CT that was done pre-procedurally and also our pre-procedural TEE. And our posterior to anterior dimension is 4.2, septal to lateral is 4, and then we get a tricuspid annular circumference, which is 12.4, which is similar to our baseline CT measurements, and our valve was sized appropriately. Our baseline tricuspid gradient was 1, so no stenosis here. We weren't thinking of tricuspid stenosis. I put this image because I really wanted to show you how many wires there are in this right atrium. This is not a straightforward case. There's multiple device leads in the right atrium, as you can see. And then now our transgastric image. As Dr. Sharma said, this is a tricuspid valve with 3 leaflets. So our anterior, septal, and posterior leaflets here. You can appreciate our device lead here adjacent to our posterior septal commissure. It doesn't appear to be interfering with the tricuspid regurgitation origin, which is more here in this anterior and septal coaptation plane. You have to trace the entire lead, not just looking in the short axis view, but in the transgastric view, trace the entire trajectory. So here again, you can appreciate the commissures at 5, around 8, and then also at 12 o'clock, which we need to know for our Evoque procedure. And then again with, this is our transgastric MPR image. We did, this patient underwent a mitral clip, and so you can see the A2P2 clip here that's well seated with a significant reduction in her MR, only mild today. Not much AR going on. And then we always worry about RV. So RV systolic function was checked with RV free wall strain, and it was negative 21, which falls into the mild range.
Beautiful. Okay, so let's go back to the presentation, and you want to just say fluoro. Let's quickly see how many leads are there. Go to the fluoro 1 second.
31.
No, we just want to show the
live fluoro.
Live fluoro, not the echo now. Live fluoro, please. Yeah.
So you see you have a atrial lead, a coronary sinus lead, and you have the ICD lead in the RV.
Yeah. So multiple leads. So, but it seems to be the leaflets are moving. Yes. So that is why we called it associated rather than related. Okay, let's continue our quick presentation. So we go. So this has been shown. This is anatomically suitable. Various sizes available: 42, 44, 48, and 52. Right?
And 56. 56. 44,
56. 56. 44, 48, 52, 56. This suggested with the 48 millimeter.
Yes.
And can, because of the diameter, you measure on the CT or how?
Yeah. So CT is worked up. This is courtesy of Edward's team. You can see that here. The oversizing on top, diastole insist they have to measure both. We usually measure diastole because that's when the annulus gets bigger. But you also want to make sure systole, and also the oversizing. You can also look at below the annulus if there's a concern about the sizing of the annulus. Next slide. And you can see that here, a lot of pictures, but you also need to make sure you have enough right atrial height clearance. So in this case, we went for a left groin access rather than a right groin access because to gain the height. And we've seen that actually from TTVR approach as well to be able to do that to get a better trajectory. So next slide. So again, this is again all worked up in terms of fluoroscopic view, where you're going to be, how you're going to start by working view on the actual case based on CT analysis. Next slide. And then you can see this is the lead that is shown on CT. Next slide, and they actually do a lot of different measurements in terms of they do it live. This is obviously a still images, but they actually, you can CT, you have a complete cardiac cycle. So you can almost simulate that to correlate with the echo images. Next slide.
So good. So now basically it turns out to be the sum it up, this patient evaluated by heart team and determined to be high risk for surgical tricuspid valve repair replacement. And now we're planning 48 millimeter Evoque valve via right percutaneous femoral venous access using TE or ICE guidance under general anesthesia. Now only question comes is to the audience, you tell why not TEER, tricuspid TEER? Why we selected the Evoque and why not the clip?
So yeah, so that's a great question. So, you know, there's always the discussion, right, when patients, now that the two commercially platform available. So number one is that how good is the imaging for TEER? As we know, yes, we can use ICE, but you know, baseline screening still rely on TEE. So the imaging has to be suitable, anatomy has to be suitable. As now there have been publications, as you know, on TTVR on the range of difficulty, right? The green case, a yellow case, or red case. And in this case, the ICD lead is quite echogenic, as you saw, that Lucy has shown. Number one. Number two is that when the device crosses, it makes the leaflets harder to visualize because now you have shadowing from both the ICD lead and the device itself, the delivery system. And then third, I think now there's emerging literature, even though the Triluminate was using moderate TR as an endpoint, we now would like to get to mild or less because for two reasons. Number one, they go home, they may say, oh, I feel great, and then they stop their diuretics and they come back with worsening TR. We've seen that in real world versus in the trial, which they're strictly managed, just like in COAP. And two, in my mind, I think any replacement platform, where it's mitral tricuspid, once you eliminate the TR, the rest is heart failure management. And that allows our cardiologists, our colleagues, the heart failure to focus on the heart rather than the valve. But the valve is no longer the issue. So I think in this particular case, with this kind of anatomy, even though, yes, we can probably get the moderate TR from severe, can we get that to mild? It's less predictable. So I think replacement is and the patient's already on anticoagulation. That's the most important. If they cannot take anticoagulation, then we cannot do, if they're contraindicated, then we cannot do replacement.
One more point I will make is RV function.
Yes.
I think that's very important. This patient only has mild RV dysfunction. and not severe, not moderate. And this patient actually had good RV function 6 months ago. So you don't want these patients to be left with moderate severe TR after doing your TTR, and then the RV continues to deteriorate. So if you can catch them early, fix their valve issue before the RV function deteriorates, they tend to do better.
Yeah, I agree with that. And we have seen that post-op, right, man? Post-op management is critical. We can talk about that later. So
let me ask you, one last question here, and then Pedro will take your question. So why not? It should be the strategy, knowing that we have two devices for the transcatheter tricuspid management, TEER, TTR, and the Evoque or TTVR. Knowing that TTVR, of course, there is a little bit of more difficulty in terms of slightly more complications compared to TTVR, which is very simple. The TEER, which is very low complication. Why not? It should be the default approach. The TTVR in the management of TR, excluding severe right ventricular dysfunction. So what I'm saying is, if severe right ventricular dysfunction, TTVR is not good. But otherwise, why not the Evoque or TTVR should be the default approach? If you cannot do it, then only you do the TR.
Well, that's a lot of debate, as you know, on the thing. But there are, as you mentioned, the need for anticoagulation, which has on the TRISCENT 2, there was an increased bleeding. In our center, we had not had the issue. And the pacemaker rate is real, right? So 20% all comers in the published literature. So those are the things that you'd have to have a discussion with the patient. There are trade-offs. There's no perfect solution. So we individualize the patient's approach. But yeah, some sites prefer TTVR because predictability, consistency, and TR elimination at the risk of pacemaker and other potential risks. And then some sites are very pro-TEER because very experienced and they believe in repair because it's safe. Patient go home the next day. There's no anticoagulation required at the expense of residual TR. And it's hard to predict which of those is better for the patient.
And which, particularly our center, you are PI of the Triluminate trial,
yes,
and presented all the up to 2 year plus data. So we know that very safe.
Yeah.
It may not be that effective comparatively, but definitely very safe procedure. Yeah, Pedro, you have some questions?
Yes. So far we have discussed the etiology of the severe TR, the RV function, and elucidated the type of procedure. What about pulmonary hypertension? If you have a severe pulmonary hypertension, sometimes just closing the TR abruptly may induce acute right ventricular dysfunction that we learned from the surgeons. Would you comment on that, Dr. Tang?
Yeah, so Pedro, it's a very important point. Remember, both trials, right, they exclude the severe pulmonary hypertension. Anyone more than 2/3 systemic or over RVSP of 70 are excluded. So we'll have to see what the real world looks like. But yes, well, the outpatients, at least for TTVR, undergo right heart cath to make sure there's no severe pulmonary hypertension present that would potentially become a problem in the post-op management for TR elimination. But yes, I think we definitely, that's why we have heart failure colleagues involved.
I think it's important to understand fixed pulmonary hypertension versus reversible pulmonary hypertension, right? If a patient has CTEF, patient has severely volume overload of the left side, you have to optimize these patients, then do your right heart cath to assess what's going on, rather than excluding them just based on the first right heart cath. So as long as it's not a fixed pulmonary hypertension, you can manage most of. One of our patients, we actually did a lot of, had a pulmonary hypertension specialist, started the patient on a lot of, endothelin receptor antagonist and all. Patient did really well. We did the Evoque device and she's doing really well 1.5 years out now. So you can't exclude it if it's reversible pulmonary hypertension. You have to optimize the patient.
Okay. All right. Let's go to the case now. Anu,
Okay.
start.
What are we doing?
Let's see what we are doing.
No, but let us see. Yeah, show the thing.
Tell us step by step.
Here. So,
Go back.
Yeah.
You have the Agilus.
So we're just going to show the audience how we get there.
Yeah, so this is how.
So this is access.
So access is from the left, but then use the Agilus and make sure that you are in the apex of the RV, right? With the wire.
Yeah, so in this case, there was a very prominent papillary muscle, and Lucy can show you. Can we show echo as well? So echo, fluoro, and hands.
That's good.
No, we need to just wait. Okay, great.
So wire positioning was guided. You can see here that there's a very prominent papillary muscle in the RV. This is from the transgastric view. So initially the wire was anterior to this papillary muscle, and we helped guide them to this positioning, which is much better for this case.
Right. And you can see that on fluoroscopy very well, the difference between the two. We save it for you, compare anterior versus opposed to where the lead tip of the ICD lead is.
So the trajectory is very good, and then, you advance the device. You have to pre-dilate.
So it's a 28 French device, and we pre-dilate with a 24 and a 33 French dilators, and then you deliver the device. So this is the fluoro of delivering the device. You add primary flex as you're going in. And now imagine doing this case from the right side, and this is the benefit, right? If you go from the left, you have to add less primary flex to get into the valve. That means less tension on the system. If we would have used the right, we would have still gone in, but you would have lost all your primary flex trying to get into the valve.
Okay, so this is where you are.
This is the home view now.
Yeah. Okay. Sure.
So you have to show what are the echo views that we are using.
Yeah, so,
right.
So I'm live on 3D right now. I just set up my MPRs. We did also, pre-going live, set up ICE if we need to, so that is also available. So here on my TE MPR, I'm in the mid-esophageal view. I created a 3D volume set, and I set it up as home. Home is defined as PASL with the aorta at 5 o'clock down here in the blue plane. So I'm in the home view. This is the device lead here, and this is our guide. And so what I'll do is I'll put our blue crosshair right at the tip so I can watch. And I want to make sure.
You think the trajectory is good with P and A?
So it looks like it is. There is some anterior trajectory to this. Otherwise,
same with septal and lateral, right?
Septal and lateral looks pretty aligned to me.
Looks good, yeah.
Yeah, it's just a little bit anterior trajectory.
Okay, so we think we start releasing.
Okay, we can go to the capsule edge. Go ahead, AK.
Are they showing the ceiling camera?
You want yeah, I got it.
Yeah,
I got
showing the ceiling camera also, yeah.
Okay, good.
Good. Now stop here for a second. Stop. So we've just exposed the capsule edge. You see the device is still at a point of return. Once the anchors are released, you go to a point of no return. It's a non-recapturable device. So just let's wait. Let's see, the gap looks a little high.
Yes.
Should we gain some depth?
Yes, please.
Fluoro?
So show the depth knob.
Yeah, so this is the depth knob. And as we go in, we're going to just pull on the... Lucy, that looks good.
Yep. You want to fix your anterior trajectory, or you're okay with that?
Yeah. There.
And a little bit of a septal dive as well.
What did you do? Explain.
So I pulled back. So I came a little more posterior because we were having an anterior dive. And we're going to just fix the septal a little bit. And you can see I'm counterclocking. And you can see how it straightens it out.
Very nice.
Very nice.
What do you think about the depth? You want more?
No, I think it's okay. Yeah.
Yeah. Should we expose the anchors now?
I'm going. Timeout. Okay.
Let's do a timeout quickly.
Timeout can. So flush port is at noon. Primary flex is 1.5. Secondary flex is 0, and depth is 1. And then the cradle is around 60-40.
Yep. Trajectory looks very good.
Yeah.
Yeah. Okay. Let's expose the anchors slowly. Slow.
Oh.
Okay, that's good.
Okay. Little.
Would go
you're a little high. You may want to get a little depth.
No problem. I will.
Just watch your positioning here.
Advance a little bit.
Yeah.
So. Your anchors are.
Floral.
Yeah, let's bring the nose cone back a little bit. Yeah, that should straighten it out.
Are you okay with A and P?
Yeah, we're just fixing it. So you see it's coming down now, a little bit more straighter. The leaflets will fall in. Yeah. That actually looks much better. Should we do a spin? Okay. Let's do a spin here. So we've corrected the trajectory you all saw. There was a little bias
Bridge.
and one of the leaflets were above. So we gained some depth here. And now it looks much better. And now we're going to spin, make sure all the anchors are engaging. At least we don't want two adjacent anchors non-engaged. So the commissures, we expect there'll be no engagement.
So in A and P, can you just highlight where the leaflets are?
Yes. So
Yeah, so that's
the
the
leaflet there, and
that's
A,
the anterior,
and this is the
that's
P.
the posterior.
This
Both
is
are
the device lead. Yep. Okay.
both are in.
So now we're going to do our spin. You guys are ready for your spin?
Yes, go for it.
Okay. So our spin.
Explain what is spin.
Yes. So what we're going to do is we're going to rotate our plane in the blue. And as I rotate here on the blue, my cursors, your eyes are going to be focused on the green plane right side. So here, you're going to make sure that you see leaflets going up and over into the anchor arms. We call that engaged. So what I'll do is I'll start. We had to give some medications.
Yeah, can we please let us know if you give meds?
Yes.
Thank you.
MAP is 50 and augmenting our blood pressure support.
So we'll just wait for that to clear.
There should be some arterial measurement, blood pressure measurement, no?
They have it. They have it.
They have it, but not us. Okay.
Okay, so there are 9 anchor arms, and so you can see them usually on the blue plane down here. And what I'll do is I'll move this green line from anchor to anchor, so from bright dot to bright dot. And again, your eyes are going to be up here looking at this side, so green box, right side, to make sure leaflets are engaged. I'm just waiting for the bubbles to clear a little bit so you can see the leaflets a little bit more clearly.
Are we saying everything is good when we are spinning?
So we didn't, I'll spin now. I think it's a good time. All right, so I'm going to spin right now. I'm at 5 o'clock, so I'm starting here. And I believe that we are engaged or we're in.
So Lucy, before you go,
Yeah.
can you tell us about the commissural position? So I think that's very important because your
Yes.
anchors will not be engaged in a commissure. So you always need to keep a track of those.
Yeah, so our comm for this particular patient is at 5 o'clock. It's at around 8:30 and also around 12 to 1. Around 12. Okay, so here we're at 5 o'clock and I believe we are engaged. I'm going to rotate to 6. So that's 6 o'clock. So you can see here that it's engaged nicely. I'll point it out. So right here. I'm going to keep rotating in our blue plane to our next anchor slowly.
Very nice.
Yep. So there's 9 o'clock.
Mm-hmm.
I really appreciate that one. That one's really nice. You can see the leaflet right there. I'm going to keep going. So this is our device lead, most likely.
Mm-hmm.
And then also you can see that beautiful engagement here.
Mm-hmm.
So still engaged. 12 o'clock now. See that device lead? Looks good, I believe. Leaflets are in. 1 o'clock. That's engaged. 2 o'clock. Also engaged very nicely. 4. Beautiful. And now we're back at home. So we did our full spin and everything looks nice.
All the
Okay,
9 anchors.
show the eyes.
You want to see ice now?
And Gilbert wanted to show some drawings.
Okay.
Yeah,
No, we were
no,
just-
this is just for
no,
us
no,
in
no.
terms of our own checklist, since it's a
Okay.
live case and, we want to make sure all the conversations are kept efficiently. So, but Sahil, why don't you explain to the audience about how ICE works and what are you looking at and the position?
Yeah, so ICE is intracardiac echocardiography, and what we have is 4D ICE, which is basically 3-dimensional ICE, and you can explain through it and recreate your 3D images. So sort of gives you a good TEE level imaging, but it takes away the sort of, the shadows and the body surfaces you have to go through because it sits right in the right atrium. So here we are at the, I actually recreated this view early on. We had the home view. I clocked a little bit, went to the valve, And then here, Lucy is going to just go ahead and tell us what she sees. So she's doing the MPR now with ICE imaging just to make sure and double confirm that we are not missing anything and all the leaflets are pretty anchored.
Yeah. So with this, there's 9 anchors for the Evoque device. So you can, sometimes the anchor maybe end up in the commissure, so that's okay. But you cannot have 2 adjacent anchors that are missing the leaflet capture. That's very important. That's why I think, obviously this is an imaging-driven procedure, not just on TEE, especially if there's any doubt, we go to ICE liberally. In fact, we have done some cases that are exclusively ICE-guided because whatever acoustic shadowing caused by the adjacent cardiac structures, remember a lot of these patients have this one is a TEER, they might have a LAO device, they might have a prosthesis, a TAVR, so those can make the imaging more challenging with the TEE, and so 3D ICE is an excellent way to do it, and I think Lucy can also do a spin to demonstrate how ICE works on the 3D MPR and ICE. Lucy?
All right, yes, so similarly, we're going to spin on the blue plane and your eyes are going to be focused on the green right side box. I just want to point out that our positioning here looks okay. We still have a little bit of an anterior positioning. So this is the posterior annulus here. You can see the valve in relation. And then this is anterior, septal, and posterior, just like on TEE. So down here on our blue plane, you can see that our anchor here around 5 o'clock is nicely engaged on the green box right side. So I'm going to go ahead and start our spin here. So that one too, that looks nice. Again, we're looking at green box right side. I'm going to keep going. 7-ish right now, 7 o'clock. That looks like it's engaged. 8 o'clock here, definitely engaged, beautiful image. We're going to go to 10 o'clock here. And yep, that looks like it's engaged. And one thing we could do, which I didn't mention previously, is that if we're uncertain, you can always lift up your blue plane and you can see the leaflets coming in on the short axis as well. So it's not as crisp. If I could show you later, I will. But we're going to keep spinning here. So that's 11. Here, this is at 12 o'clock now. So that I'm not too sure about, but we did see it on TEE.
So Lucy, 12 o'clock is where you said there was a commissure, correct?
12 o'clock was the commissure, yep.
Is that where our lead is straddling next to it?
Our lead is right next to it. So that acoustic shadowing that you're seeing, that is the device lead.
So you think we could be in a commissure?
Yes, I think so. Actually, the leaflet may be there and that we're just having a shadow. So,
gotcha.
Yeah. So I'm going to keep going here. So there is 1 o'clock here.
Can we change the ICE position?
Leaflet looks good. No. And then...
it's fixed.
Yep, and then here's 2, 3 o'clock, and then we're back at our home view here. So spinning on T and ICE are both good.
Okay, so great, Lucy. I think one thing for the audience to know is that you can see the ICE images, you can see the leaflets in better resolution. So that's very important, especially you have any doubts. And number 2, the workflow is the same. So Lucy showed you exactly TEE and ICE. You should have a reference point when you communicate with your implant team so no one is confused about what the o'clock position. And it's very important to highlight, as Lucy mentioned, the commissure position, because remember, not all tricuspid valves are 3 leaflets, right? We know from Becky Hahn's paper that it's 4 leaflets, there's 5 leaflets. We need to really make sure we know where the commissures are, because as you saw here, the commissures can be actually where the anchor is. So even though you don't see the capture, it doesn't mean that it's not captured. It just means that you cannot see it. And I want to show you just a quick fluoroscopy image. There was a question about that particular lead in the way of the anchor, and if we can see that, we go an LAO projection to see the lead is actually nicely tucked in between the 2 anchor points. So that actually is a good sign, because that means the leaflets are not being impinged by the lead, but being pushed and displayed to the commissure. So you want to comment on
no,
that?
I think we need to continue expanding now.
Let's go.
Yep.
The question is, can you do TTVR without ICE?
Yes.
Go ahead.
Do you want to stay on
If the
ICE?
imaging is good, yes, you can.
Stay on ICE, Lucy. Because the valve has to expand now. Go slowly.
Just watch the posterior. Yep.
It's good.
Yeah. Keep going.
I'm really going.
Slow. Keep going. Keep going. So, yeah. So see how the valve expands at this point? It's the inflection point. Just watch the wire. Good. Good. Now stop here for a second. Let's go back to TE now, please.
T
No,
coming.
it looks good. Why
Yeah,
you
let's go
PE
back to
again?
TE.
Let me flow safe. Hold on one second. No, because what happened is that that's a great point brought up about TE versus ice in this situation. So once the valve expands more, you shadow more,
Shadow
right?
more, correct.
So ice may get through some limitations. So we like to go sometimes back and forth to see which is better, give you more confidence to deploy the valve, right? So we are not, but don't get fixated on only one particular imaging modality. So
You have to keep it on, yeah. Okay, let her fix her image. Give Lucy a second, please.
yeah.
Coming.
Yeah.
But you can see even nice on 2D that the SL, right, we call PASL, so septolateral on the red box is already, you can see the valve fully engaged with the annulus, with the anchors. Now we need to make sure the AP is also proper. Remember, that just in terms of a little anatomy lesson for the audience, the tricuspid valve is large and it's D-shaped like the mitral. The AP dimension is the biggest. The SL usually is the narrow because the way the RV is shaped. So the contact of the anchors will be SL first,
Correct,
before AP. So you have to make sure you don't miss the AP, even though you capture the SL. So it's very important.
So that
for
is
the
why I
audience
wanted
know
to
that.
switch to TE because I was having concern with the AP. So Lucy, can you tell me about the AP now?
Yeah.
Everything looks good?
So AP does look better. I'm just watching that posterior.
Yes.
Seems like it's okay. You may want to get a little bit more posterior. Try to get it behind here if you can.
Correct. And if you see the fluoro, your anchor is away from that lead. So that tells me we may need to go a little more posterior, slightly more.
Yep.
You went
Good.
posterior?
Now you see it on the fluoro? Dr. Moreno, did you see that?
Yep,
That's better. Yep.
it moves beautifully.
I'm releasing.
Keep going.
Flow safe.
Slower.
Huh?
Yeah.
I just want flow safe.
Yeah.
Yeah.
Good. Keep going. Keep going.
Yep.
Keep going.
Watch your lateral.
Yeah. Watch your lateral, guys.
Blue knob. Good. Now we are okay.
I want to check lateral 1 second.
Yeah.
Where's your eyes?
So
Yep.
Where
Lateral.
it be?
Lucy, lateral may be okay. Can you check again what you're seeing? Maybe in the commissure. Can you check again?
Yeah,
Yes,
and
yes.
also make sure
Promise.
sometimes you have double shadow, right? So that's when ice can be useful too. On the lateral side, we have been having some challenges with the double shadowing artifact of the device with the lateral annulus and TEE. So we sometimes might actually like to go back to ice to confirm that.
So at this point, the leaflets are pretty engaged, by the way. So your valve is going to be stable. It looks like it, but you don't want to miss one side and then the valve cants and you have PVL. So just because even in the RV side, you can have these splaying of jets causing PVL.
Just speaking through the lateral side here, it seems like it's a little high to me.
Okay.
Ready?
Too
long.
I would bring it down a little if you can.
Yeah. So,
Okay,
so we're doing some secondary flex.
Sorry. Just a bit more secondary. Yeah, keep adding. Yeah. Little more. You have more room. Good. Okay, Lucy looks much better now.
I'm not quite home. I'm just checking. So now I'm going home. Still.
I think that leaflet is engaged. Yeah. I think it's giving you an impression.
It's better now. You can see that. We also optimized the AP as well in the
Not yet,
meantime,
wait.
because when you do your secondary flex,
Yeah. Lucy, I like it. What do you think?
That lateral's still a little high for me, but
Want to check on ice?
yeah, check on ice. Just
sure,
one
we can
time.
check on ice.
Yeah, check on ice because I don't
This
want to double
looks- so it
shadow.
It looks good here. I actually think it could be okay. All right, I'm going to switch to ice.
Yeah, switch ice.
Okay.
Yeah.
I'm releasing.
No. I just want to check on
One
ice.
second.
Yeah.
Can we,
He's saying it's good.
Dr. Kinney's speed is a little bit different than our speed, so.
can we adjust the ice, please?
Yes. Yeah. So help me.
Yeah. 1 second, Lucy.
But you can see fluoroscopy, right? How the valve has tilted towards the lead, and now you can see the anchor engaged. So also don't forget that fluoroscopy is your friend when you have other devices in the way. So you can actually see how the trajectory have changes. So
you see how you're shadowing more now with the device fully expanded, even with the ICE catheter. So let me just try one thing here. Sorry, guys. Okay.
Go to the LAO. I'll tell you why. And then
Let's engage.
ICE can be on top of it.
Okay.
there we go.
All right. Now let me fix this image. Lucy, just stay there for a second.
Yes. Other way.
Yeah, I am just trying to free it up a little bit, and I'm going to give it a little tilt and then open it up. Here, 1 second. Okay, go ahead. See if you can recreate some image there. And just give me 1 second. Okay, go ahead.
That looks good. So with ICE, this is the Philips VeriSight Pro system. You can see 40-45 give you the best resolution of both image. Otherwise, if you do 0, then give you a minute, but the 90-degree, because the way the catheter array is designed, it's not going to give you the best resolution. So we try whenever possible, manipulate the catheter so you can get the optimal 45 degree image, which you're seeing here. So again, what Lucy is creating after Sahil has acquired the image is to get the same MPL view, and this is just again to finally confirm that we have not been too high on the lateral aspect of the annulus. And of course, just before we deploy, and we probably can deploy in this view. So again, you don't have to go back to TE if if this is satisfactory, and we can just keep on this when we
Good.
do the deployment. So we just once Lucy has finalized the image, then stabilize it, and then I think we should be good to go if everyone agrees that this is a good deployment position.
I've been ready for the last 15 minutes.
So the posterior annulus is okay, right? Because you see it's a little bit of the...
Posterior is okay. I'm
Yeah.
not too worried about
I think,
posterior.
Gilbert, that's the
Yeah.
lead,
It's
giving you that
the-
impression.
Yeah, it's the
I think the
Okay.
leaflets are fully
It's not
engaged.
too low, right?
Okay.
No.
Halfway on blue and then advanced T-flex.
Okay. Okay, go.
He has approved it, my friend.
Okay.
Let's go.
Go ahead.
Okay.
Okay, we're going to go ahead and release.
Let me flow safe when you do that.
Yeah. Go slow.
Do it on ice.
Hold the wire.
So I'm holding the wire. The nose cone is already pulled back, as you see.
Go slower.
Advanced just T-flex and the stabilizer.
Yep.
Yeah, just a little bit. Good. That's good.
You can fully release.
Fully release.
So you can see now how the posterior annulus rolled up. Yeah, you can see that.
All the way back.
Yeah. So good. So now it's released, okay?
Okay, just stay here.
How are you going to advance the wire a little bit?
No. Full save that?
Yeah, I saved it already.
Okay, good. Okay, good.
Lucy
All right.
looks good.
Yes, I'm looking at your nose cone now. Yep.
Okay.
Pull it back.
Are we in the center of the catheter for the nose cone to be retrieved? We're a little
You are,
bit
you are.
of
A little bit more
yeah.
anterior position.
Yeah, a little more anterior,
Yeah, we are
right?
fixing. We are
Yep.
fixing.
Right
Just
Good.
there. That's better. You're central.
yeah. Good.
That's good.
Your nose cone, and then take off your depth.
Yeah, that's the nose cone. Yep.
Fish the wire slightly.
Yeah,
Good.
I will. So this is, as you can see, this is a 2-operator job, right?
Good.
So you can
Push the
see,
wire.
in addition to imager, we like to make sure the nose cone is completely clear from the atrial. As you can see, it's
You're clear.
yeah.
Yeah, we're clear.
I'm gonna go ahead to T now.
Good. So the nose cone is clear. Okay. Good. So now the rest of it, you just remarry the system, which you can show the audience
So
here.
all the flexes are off now.
Yep.
I'm gonna
All
go
the
with the
depths
blue
are off.
first.
So you have to remarry the capsule and the nose cone. So you can see that's what Sahil is doing by going back, the blue knob first.
You're still across.
Okay.
Yeah.
And then we step the wire across. So once it's ready, I'm going to bring the wire back. So the wire is literally right across the valve. Okay. So the wire is out. Okay. So you don't need to exchange. You don't need to do anything. Obviously, you want to be gentle.
Very
You can see
stable.
the valve is very stable. The lead is completely engaged. And so I think we can give protamine and get this out.
Okay, start your lecture.
Sharma.
The Doppler.
Yeah, no, but let's just show that.
Yeah, let's quickly
the
show.
TR is bye-bye.
Yeah,
Yeah, it
we'll
is.
show- yeah,
The
okay.
Doppler.
It's like
Doppler, color, all those good things.
So there's your 3D of your valve. You could really see the nice device lead there, pinned against the wall, between the wall and the valve. And absolutely zero TR on. Beautiful.
50 protamine, please.
No PVL.
okay.
Okay, well, all
good.
right.
Really nice.
Okay. Wow.
Incredible,
Very
yeah.
good. Incredible.
Fantastic, everyone.
Let's do some nice at the end.
Unbelievable.
Okay. So let's go to our presentation now. So that we have another 7-8 minutes to complete our presentation.
out.
Today
Take this
we'll
out
just
first.
talk about the recent TTVR publication about the Evoque
What did you say?
very trial, the real world early experience
Go
and the
check.
mechanism and management of the CIED lead related TR. So this actually the landscape of the tricuspid valve, and the green basically is the randomized control trial, and more importantly the single the star is with which is the mark CE mark approval, and the red I have put it which is the FD approved. So Evoque and TriClip both are approved here, and of course they happen like at the same time, similar time last year in March, April of 2024. And of course, many of them are investigational, ongoing. We are part of the Intrepid, Mitral, and Tricuspid, and many of the trials actually have been away. So one in the red is not available, clinical, because it was not good. But some feasibility trial are ongoing, including of the Intrepid and even the Pascal for the tricuspid valve. So this is a nice summary of the management of the tricuspid valve where we have come. One is medical therapy, which is very limited. That is just using the diuretics. Very limited role compared to mitral. We have a lot of particularly functional MR, guideline directed medical therapy, but here is a minimal efficacy of the medical therapy, and then go for surgery, which over the decades has about 10% mortality. So that actually based on the STS data has not changed in last almost 10-15 years. Then we got two devices. One, put the clip together, which is the TEER, or you get the replacement TTVR, which we showed today. So clearly they all have a plus and minus. The biggest thing with the TEER is very safe, effective, moderately, but does not eliminate and have a nice quality of life parameters improvement compared to TTVR, which is a greater degree of TR reduction, but appears to have a greater rate of procedural complications. And of course, these are all in the early stages, and more we'll see based on the trials which are coming. These are the, the original tri-valve. Basically, the Abbott, the particularly mitral clip he used to use for the tricuspid valve. Those are the data of the tri-valve. Then, of course, tri-illuminate, which is Sinai being part and PI. For the randomized trial, and then of course then TriSend registry, which is for the TTVR, all have shown that good use of these technology in appropriate patients after good training. Now, which we have shown quite a bit here, 9 anchors of that nitinol frame. You saw that very clearly, how we looked into it with the echocardiographer guiding and the various sizes available. It's a 28 French delivery system, and sit very nicely and eliminate the regurgitation, and then of course the delivery system, which step by step has been shown, and you can get into it and so. So for first one, the whole question is, this is a very, I would say, is skill dependent technique. So particularly that various techniques, how it should be done, intraprocedural guidance, which you saw quite a bit for the echo as well as ICE, Evoque implantation imaging. The data was initially from Rebecca Hahn, and then of course now we are from our center with Lucy Safi and Sahil, the first and senior author, giving the intraprocedural guidance for the transcatheter tricuspid valve replacement in challenging scenario. And basically using various fluoroscopic and views along with the TE, and then of course have in terms of the sub ice, as you show practical demonstration exactly, then a challenging scenario of the implantable lead as well as the prior TEER. And we actually have done cases. How many cases we have done with the prior TEER and using the Evoque? For 3 or 4? Yeah, more than 5. So per tier we did, failed, and then use the Evoque valve. So all the step by step has been a very nice manuscript written in this cardiovascular imaging by our group. Took a lot of time, lot of changes, but it is an excellent review for those who want to learn step by step techniques. Then basically another paper came at the same time in terms of echocardiographic imaging, how to define what is the malposition, ectopic, migration. Again, these are all technique dependent. We actually have about the CT analysis. Another paper came from our center in terms of the CT analysis of the Evoque valve. How does it look? Tilted, where it is in the inflow, in the outer frame and the inner frame, and then the remodeling. So this is one of the big issue always happens, that you have now replaced the valve completely, then what happens in terms of the right ventricular dimensions and so. As you can see, post tower, definitely ejection fraction, post TTVR, EF does go down and the remodeling does occur as has been shown in this our abstract presentation. Then the other 1 year outcome. So overall, after this initial data, so we have then 1 year outcome of the Evoque tricuspid valve, and this is what a few years ago from Webb, 27 patient, excellent results with a 7% mortality, 7% hospitalization, and more important on the right side, that almost elimination of the severe or torrential TRs. You just left, even at 1 year, about 5-8% of the mild of TR. So this is the one thing which was very clear, that clear elimination of the severe tricuspid regurgitation with the Evoque valve consistently, and of course the pacemaker rate is about 15%, as shown in this initial first experience. Then the Transcend, basically showed that if you take individual endpoints, in terms of pacemaker rate was 12 to 17%. Some complications do occur, and one of them is the severe bleeding. Vascular complications are less because it's a venous and we know exactly what to do, but severe bleeding, particularly because you have to give anticoagulation to these patients, is one of the clear-cut concern, and earlier pointed out with by Gilbert also, that if you cannot give anticoagulation, then you are not putting the Evoque valve. And of course, in terms of NYHA class, KCCQ score, and the TR grade, gradient, and 6-minute walk, all improved by using this is the earlier data. And then of course, in terms of also, this was a single arm, the decreased hospitalization pre versus post. So clearly effective technique, and this is putting the summary together, that yes, Evoque was at the first line, was a Transcend study, which is a single arm, but the data comes only by the randomized trial. And then basically came with the Transcend 2 trial, and that is basically the using the TTVR in severe plus tricuspid regurgitation using Evoque, plus medical therapy versus medical therapy alone, with 30-day, 6 months, 1 year, and then of course every year follow for 5 years. And data showed basically is that your hard endpoint, particularly hospitalization and death, was no different in the optimal medical therapy group compared to the Evoque group. But what it did do is that KCCQ and walk distance, reduction in TR and NYHA class, they all improved significantly in the TTVR group without any difference. So maybe Sahil, yeah. So question is, other trials also have shown that understand the mortality, because these are very sick patients, is very high to begin with. But what if, why not even the hospitalization decreased? Now, Triluminate also was the same thing, right?
Yeah, so 2 years in Triluminate, it demonstrated reduction in hospitalization. So I think it's just too early.
Too early. Okay.
Yeah.
So therefore, although hospitalization was not decreased in 1 year, it likely at 2 year will decrease hospitalization. I think that's really will be the testify the truth of the device that yes, it works, because everything else is subjective. Quality of life, KCCQ score, and so forth, but we had to see. Now, what they also did in this called win ratio. Win ratio is take a hierarchical endpoint in both of them, and it showed basically that 6-minute walk test, and if you take that replacement group, the hospitalization was lower with the win, although it was 9.7 versus 10, but there is a very fancy statistical calculation of the win ratio, and so. Now, other outcomes are shown here: the higher bleeding rate, new pacemaker. Those are the very important two important aspects we always had to think about, and the vascular complications were slightly higher, but not significant. But key is, was clear cut, higher bleeding and higher pacemaker rate, which we noted in the device arm. And the quality of life, as we said, part of it is improved by using the TTVR. So therefore, clearly the quality of life placement, as well as the data, as well as the walk test, and so all suggested the TTVR is beneficial in this sick patient, and that led to the approval of the device. So now question is, what if you get to the regular life, usual run-of-the-mill cases in the real world, transcatheter tricuspid valve replacement just published, is still in a very early stages of about 150 plus cases in the various countries in the Europe, which is shown there, with 1 month follow-up, although patients are being followed. These are the patients in the real life situation. We always know real life data are a little different than the trial data, because trial patients are very well monitored. They have inclusion exclusion criteria, but in the real life you have to take care of everybody. And these are the data from this year. And what they learned basically is that patient, of course, elderly population, and outcomes at 30 days age is a success rate of 87%, improvement heart failure class by 71%, renal function improvement, and reduction in the bilirubin level. So key is, many of these patients are sick, were not part of the TRISCEND 2 trial, but in the real life you have bilirubin of 3 and 4. So really, the various metabolic derangement, liver disease, liver ascites, all those significantly decreased in the TTVR group. Now, predictors of clinical failure, that if you have moderate or severe RV dysfunction, those patients fail, as you can see, within 1 month. 28% versus if you don't have RV dysfunction. Second is the need for pacemaker implantation. If you have conduction disturbance, incidence is 28%. No conduction disturbance is 8%. So basically what authors concluded, the successful TR reduction after TTVR was associated with significant improvement in functional status and hepatorenal function. Both creatinine went down, bilirubin went down. And moderate to severe RV dysfunction predict clinical failure, and conduction disturbance at baseline predict pacemaker implantation. So clearly, usually what we have learned it, and it's a good thing to have, that now real world data corroborate extension of the TRISCEND 2 trial. And that basically was the trial data. So therefore, we still have a lot of challenges. So we now going from TOWER to TTVR, because those are the two valve replacement. Mitral is still lagging behind. Pulmonary, we keep it for the kids. The Evoque in trials versus in clinical setting, we already have the data. TR symptomology and promise of the TTVR, promising safety with caveat, clarifying boundaries of the therapeutic benefit, and early data, limited scope because we have only 1 year, and really benefit will occur from 2 to 5 years to be seen, and so. So question is, you have only 1 year data. There is actually case report of the 4 year. So 1 year, it lasted for 4 years, so that's very good. And just to say that 84-year-old patient after 4 years of torrential TR in 2019 continues to have this paper published in the JACC imaging. Now, the last one, tricuspid valve disease and cardiac implantable electrical devices. I think we have spoken quite a bit. There are various mechanisms, basically laceration of the leaflet, avulsion, impingement, dysfunction, mobility, that what we should be doing, who are these patients. more leads are there, more are the chances associated with, and native right ventricular dysfunction. So basically, your left ventricular causing the trouble on the right side, your TR will continue even if you have, and that is a classical CIED associated TR, not necessarily related TR. And this is actually data on about 1,000 patients with a pacemaker implantation, and you can see tricuspid regurgitation does progress, and we also know once it has anytime you have TR, you have a higher mortality as shown on the right side. But key is the RV dilatation has a lot to do which patients will do worse after these pacemaker implantation, because even if you put a lead and it's not causing any trouble with the leaflet, it is still continue to do a more severe TR regurgitation. Now, there are a lot of algorithms here, which those who are expert and who want to have a deep dive, I have put it together here. The algorithm for implantation, lead extraction, and what you should be doing in these particular cases. And I think we have shown already that you can, in many cases, you can impinge the leaflet lead against the TTVR leaflet, and nothing happens, and they continue to do quite well. So just to sum it up, now we have two effective strategy, both TTEER and TTVR. And of course, you have to decide which one is good for your patient. Second, initial early strategy of Evoque TTVR, very good with a limited complication. And then Transed 2 trial, we understood, very effective, consistent, 1 year, and the win ratio was positive in favor of the TTVR device. Only question remain is the bleeding and need for pacemakers. So those are the two caveats we still have. But if we know it, then we have our better post-procedure care, and our skills, procedural skills will change these things subsequently. Then lastly, the CIED-related TR is increasingly being recognized as an independent clinical entity, and we have to think about it. And of course, the various novel technique, and particularly many of these cases using a leadless pacemaker also will be helpful in the management of these patients. So quickly, our three questions. Following are the component of the Evoque TTVR device except 11 anchors, nitinol frame, sealing skirt, 28 French delivery system, tri-leaflet bovine pericardial tissue valve. Remember, there are 9 anchors, not 11. So A is wrong. Second, the following outcomes are true regarding the results of Transcend 2 trial, TTVR with medical therapy, similar deaths from any cause between two groups, similar hospitalization from heart failure between two groups, similar NYHA class change more than 1 between two groups, similar death and heart failure hospitalization between two groups, and similar stroke rate. Clearly, it was TTVR effective in reducing the NYHA class. So more than one change occurred in significant number of cases compared to medical therapy, though C is wrong. Lastly, again for the Transcend 2 trial, what is the wrong? Better symptom improvement in the TTVR group, better improvement in quality of life, higher bleeding in TTVR group, lower need for pacemaker in TTVR group, and significant reduction in severe TR at 1 year. Clearly, pacemaker is higher in the TTVR group compared to medical therapy in the Transcend 2 trial, and I complete my presentation.
Well, thank you so much for the Cath Lab team for this incredible case, and thank you for joining us today. Remember, this case will be archived this afternoon, will be ready for your review at ccclivecases.org. And we do our structural heart life cases every month on the second Tuesday. The next one will be September 9 at 9 a.m. Thank you so much.